I think we'll try to get started, and we may have a few people coming in through the door after they were fan people for David Saunders probably, as am I. But anyway, we're so happy to be here today, and Father Dan Knaup is an Episcopal priest and has a lot of experience to bring to bear to what's been happening in the past year, most notably supervising and organizing vaccination programs. There's Dr. Danny Zorab. I was telling him about you. Anyway, I'm kind of mumbling. Here am I on Facebook Live. Yeah. Okay, so Dan is going to share with us the story from the inside. And we will have plenty of time for questions. I have a microphone to bring to you. And I also will be monitoring Facebook questions for those of you at home watching. So welcome to Dan Knaup.
Thank you. Thank you, Sarah. Great to be with you all this morning. I was hoping to give a little perspective on both our vaccine rollout at Mercy Health here in the Mercy Toledo region, but a little bit also about some of the other issues with COVID that I've dealt with, some of the issues of trauma that we've faced amongst healthcare workers, and talking a little bit about maybe the future. So let me begin. Next slide, please.
Hit your letter N.
Pardon? I just hit, here you go. There we go. Myself and Craig Albers, hospital president, he really has worked tirelessly leading us through this program. I can't say enough about the great leader that he has been. A wonderful mentor as well. May is National Nurses Month, so I thought it'd be really important to recognize our nurses, our frontline caregivers, and especially those who I've worked with very closely. Our intensive care nurses especially have faced a huge challenge during the COVID crisis. This is the cutting edge of where we've done our care with COVID patients, and our intensive care nurses have been absolutely phenomenal. Just a picture of one shift of our ICU team. I did want to share a little story about one of our nurses who received an award recently, just to give you a little feel for what goes on with the wonderful work they've been doing. This is for Nurse Jessica. So we had one particular patient mid-pandemic who was on and off the ventilator to BiPAP, where she languished and suffered, only to find herself back on the ventilator. Jessica was her nurse and who voluntarily quite often took on this difficult patient, even though she was an aerosolizing COVID patient. On the day she finally couldn't make it on BiPAP anymore, she knew she would never come off that ventilator. And Jess and I were in there, called her husband for her, and relayed her final words to him. He was in the lobby dropping off pizza to her beloved nurses that she had ordered by text message. Her last lucid moments were spent laughing and teasing Jess for promising she would eat a dreaded veggie pizza if she survived. Unfortunately, she didn't. We went to the funeral home to tell the husband what a wonderful patient his wife was and how strong she was right to the end. I could see how much he appreciated her and how much healing it gave him when he saw that Jessica, his wife's nurse, was there. I am thankful to have Jessica on my team every day. So just one sample of many, many stories like this that we heard and faced during this last year amongst our healthcare workers, our doctors, our nurses, our other frontline workers. Many other stories just like that. So if you could see this graph a little bit, you can see the kind of how the crisis rolled out mid-March. It was March 16th. We really started feeling it in our region, Mercy Health, and we peaked out at 107 patients around April 6th. 107 inpatient COVID patients throughout our metro hospitals, which includes St. Charles, St. Vincent, St. Anne's, Perrysburg Hospital, Tiffin, Willard, and Defiance. So we were up to 107 patients on that day. And then you could see this graph of how the kind of would go up and down in that very first wave in April. And then around June 8th, it kind of dropped a little. Our numbers really dropped around June 22nd. And then with the 4th of July holiday hitting, we had relaxed a little bit. There was more relaxing of standards, and then you see that next wave happening in late July and August. So we jumped back up to 55 inpatients on August 3rd before gradually tapering off to 21 by 9/28. And then here we see the next graph. Our numbers started dropping significantly until we started getting into the November time frame. In November 24th, 109 patients. So we exceeded that wave 1 number of inpatients. And then with Thanksgiving, people gathering around Thanksgiving, the numbers start rising again with wave 2. Right around early December, we were up to 134 patients in our hospitals, COVID patients and inpatients, beds in our hospital. And then that started dropping once again. And then this last slide will show kind of what I just talked about. December 134, once again, we peaked around 1229, actually 12/9, before kind of dropping a little bit again. And then you had the post-Christmas lull. And then Christmas, people gathered, it rose to 100 again. And then what happened at the end of December into early January is the vaccine program started rolling out. So I know I got one of the earliest vaccines at my hospital. I was vaccinated on December 22nd with the Moderna vaccine. And then we started seeing, as more and more people started getting vaccines, you see that drop off into February, March, to where on March 5th we were down to 16 inpatients, which was just amazing for all those hospitals. And then we see another slight uptick again into April, and this is what I would call wave 3. And Michigan was really the recipient of that heavy wave, especially with the UK variant up there and the Detroit area. So once again, our numbers rose to like 50 inpatients on April 12th before stabilizing again as the vaccines rolled out. So this is just a picture of my vaccine team at St. Charles, and then the various hospitals in this Toledo region of Mercy Health. And in the middle is Les Maugel, Director of Pharmacy, who's just been an anchor for me and for all of us. One of the flyers we put out about facts about COVID-19, so many people were questioning some of the science, and this was just a handy guide that we would give to people, and we tried to publicize as much as we could, what are the facts about COVID-19, because there were a lot of bad information going out there, just to try to reassure people. So a little bit about our vaccine rollout. I talked a little bit about the waves of COVID patients. So around December 22nd, these are some of the notes from our hospital incident command team meetings. Thanksgiving surge was more like a tornado picking spots, more so than like a hurricane. We were seeing this across the ministry. Cell phone tracking by Toledo showed travel was down greater than 50% over the Thanksgiving holiday. And Moderna was saying that the worst case, it would take 6 weeks to tweak the vaccine variant if the strain evolves. And then we continued to develop in late December vaccines as a single dose, and I'm sure a lot of you were following the news and you were aware of what was going on with this. But we were looking at, as long as people got that single dose, that would be, rather than getting both doses, it would still be 90% effective. And then you can double the number of people that got vaccinated if we just started giving that first dose to everybody. And early on, the primary goal was no excess vaccines. And that although we don't have a crystal clear picture of who will be vaccinated, our goal was no excess vaccines. And then into January, nationally, we crossed the 400,000 mark as far as COVID-related deaths, which was a grim milestone. 45% of our healthcare workers were vaccinated in the Toledo area, but illness and lost work continues. We had a lot of caregivers who got COVID-19, who were very sick, and that affected our ability to take care of our inpatients. And then the conversation was shifting to the lingering side effects of COVID-19. Vaccination clinics, we started with 1,200 dose clinics at our flagship hospital, St. Vincent, doing 300 doses per clinic at St. Charles. And then we were looking at doubling and tripling our vaccination efforts at this time in January. March 15th, we hit 535,000 COVID deaths nationwide, 2.7 million deaths worldwide. The good news was Americans were getting extremely diligent about getting their second COVID shot. So we were very happy to see that there were virtually no missed second appointments for those getting the Pfizer and Moderna vaccine. The no-show rate was virtually nil, as everyone was showing up to get those shots. And then our Mercy began to shift our strategy from having individual vaccination pods at each hospital to going to large regional medical centers, supporting them, 4,000 to 5,000 dose clinics at Lucas County Rec Center. So we started rolling into that. Logistically, it was a lot easier to do it that way. There was greater access for patients. It was easier to get them in and out, and then we could all pool our resources and our staffing at the rec center. We also were concerned about the disparity in vaccines amongst our underserved populations. And so we began implementing equity pods that would go out into the community and to give vaccinations to those in areas that were traditionally underserved, minority areas. So we set up sites at places such as Central Catholic and we work with Neighborhood Health Association, one of the local federally qualified health centers in the area, to get vaccines out to those in great need. And then hope on the horizon. On May 1st, we were at 575,000 COVID deaths nationwide and 3.2 million deaths worldwide. And so we began setting up closed pods. What that means is basically it's not a public pod that everyone could come to. It's a pod where we just closed it and it was only available to certain constituencies. So we went out to businesses such as Jeep, Honda, Johns Manville, Perrysburg, Clay, and various Catholic high schools in the area to give vaccines, and that was very successful. Another therapy that we rolled out at my hospital actually was the Lilly monoclonal antibody infusion therapy, utilizing both the Lilly product as well as Regeneron. And we found these to be very successful in treating sick COVID patients who would probably be hospitalized if they didn't get these monoclonal antibody treatments. So St. Charles was a test site to use these for the Mercy system. I know ProMedica also had a site doing these monoclonal antibody therapy, and we're continuing to do these with great success. It's really made a difference in reducing hospitalizations for sick COVID patients. And sponsor Mercy Health, we've administered over 400,000 COVID vaccines in Ohio and 114,000 in the Mercy Toledo region of those 7 hospitals I mentioned earlier. Vaccine Week was May 10th through 16th, an effort to really educate the community and get them out, try to push more vaccines. And we were focusing on Jeep employees. There was just a picture of the vaccine clinic at Jeep, giving vaccines to Jeep employees and their families. I'll talk a little bit about the human cost, what we faced. This quote is from Paul Tillich, who was a theologian, a famous theologian and a military chaplain in World War I. The courage to be is found in the God who appears when God disappears, in the anxiety of doubt and fear. And Paul Tillich was greatly affected by trauma and his experiences in the ministering to soldiers in the trenches of World War I. He was a German chaplain. And after he left, he was devastated and he basically lost his faith for a number of years. And a typical reaction to trauma, he wondered where God was in all of this. It was rather hopeless. So he eventually found his way back to God. Reflections on the human cost of all of this. We've had almost 33 million confirmed U.S. COVID-19 cases in our country, 163 million nationwide. We've had 586,000 deaths in the U.S., 3.4 million worldwide. Just to compare, this is greater than all of our deaths in both World War I and World War II. Both these are combat deaths. Hospitals, especially ICUs and ERs, were overwhelmed during these surges. I know that all of our hospitals were overwhelmed, understaffed. The strain on staff, doctors, nurses, caregivers, personal protective equipment, supplies were intense. And we went through so many sessions, strategy sessions, trying to get these things to our frontline workers and our patients. Families mourned lost loved ones, funeral restrictions. I talked to you a little bit about a nurse who had to be at a dying woman's bedside. That was quite common. Family members could not be at the bedside of their loved ones who were dying of COVID. Many times it was the doctors or the nurses who had to be there for them. They were their contact. We used sometimes iPads to allow family members to talk to their dying loved ones, but that's just not the same. Talking to someone on an iPad as they're dying. But we did the best we could at that time. I myself lost my mother-in-law to COVID, a very difficult personal loss. We also were not able to be at her bedside. We face physician and nurse trauma and burnout. I'll touch on that a little bit in a minute. Basically a loss of hope, something that when you're faced with overwhelming bad news constantly over and over again, it just eventually it affects you. Political polarization, the politicization of COVID-19, we saw that with our election. The whole mask versus no mask, vaccines versus anti-vaxxers. This causes tremendous stress in our society. It also causes stress at the hospital. We would have many patients and visitors who did not want to comply with our guidelines. And it was difficult to try to tell them, unfortunately, this is a healthcare facility. If you want to come in here, you'll need to wear a mask. We got a lot of pushback. And then the social isolation that so many people have faced during this period, job loss, financial family stresses, addiction. Addiction has risen tremendously during the last 14 months. I reference an article here, Nurse Burnout, the Next COVID-19 Crisis. Jessica Rainbow at University of Arizona, talking a little bit about what she saw, and I can certainly confirm a lot of these findings, that the pandemic's basically on the verge of breaking the nursing workforce and to a larger extent healthcare at large. What we found when COVID-19 started peaking was that many of our nurses who were baby boomers decided they were just going to retire. They didn't want to face this anymore. And we had a lot of other nurses that just said, we're just going to quit. This is just not for us. So unfortunately, we faced a large turnover. At the same time, there was a nursing shortage. We did what we could to try to support them in many different ways, offering various wellness tools, pastoral care, pastoral counseling, opportunities for relaxation and stress relief. But when you are understaffed and your patient volume continues to increase, you're basically in crisis mode all the time. So it's sometimes difficult. in how can the public support nurses during the pandemic, we did see a tremendous public outpouring of support for our healthcare workers. And it was just overwhelming to me. I was just touched by how many people offered us so many things: free meals, gifts, spa treatments, tickets to events, so many things that the public offered that were very wonderful to see that support. Burnout, alcohol, PTSD, healthcare workers are suffering. Another article from the Yale School of Public Health that suggests, surveys suggest that 1,000 healthcare workers are facing worrying rates of depression and post-traumatic stress disorder amongst the worsening pandemic. And I personally could say I saw this day in and day out. Those of you who work in healthcare may have seen the same thing. It was just a very difficult time. And some of the findings of the study did point out that female gender was sometimes associated with probable PTSD, mostly because the majority of nurses are still female, although we have a rising number of males getting into the nursing profession. Healthcare workers whose teams had lower cohesion were also more likely to face disorder as well. And then the probable general anxiety disorder was more common in those who reported having a decreased satisfaction with the federal government. We really need to be creative with ways that we're able to nurture social support and social well-being among healthcare workers right now. So I had, you might have seen in the bio that I've spent some years as an Army chaplain. I served in Afghanistan and Iraq. One of the things I saw a lot was PTSD. I would say that it's possible that I suffered it as well, or at least parts, some aspects of it. And what I saw were some similarities between those veterans who experienced PTSD and frontline workers who experienced trauma stress during COVID-19. These are just some of the things that are associated with PTSD. Not all of these are, part of the symptoms that we all face, but I'm not going to read through all these, but you can see the behavioral issues, psychological issues, severe anxiety, mistrust, mood swings, loss of interest in activities, insomnia or nightmares. Also common emotional detachment, difficulties in relationships. We often see that. Feelings of depression and being down for long periods, isolating yourself and withdrawing from important relationships. And then the substance abuse that rises so much amongst those suffering from PTSD. So we tried to offer our nurses, our doctors, our frontline workers as many resources as we could. Our pastoral care team, our chaplains were extremely busy during this period, working the floors, talking to the workers, of course they had the burden of patient care as well, but we also offer various programs such as counseling, Be Well Within, which is the name of our wellness program at Mercy, and other opportunities to help give people a chance to talk. And I myself also had an opportunity to talk to a number of staff and do some counseling myself. Mercy's reaction to all of this, we did open up our outpatient behavioral health. We determined we really had a great need to do that. So Mercy saw a 51% increase in outpatient behavioral health visit volume the last 12 months. Those numbers really jumped. And we extended our support to all of our primary care offices. We also expanded our behavioral health support to women's health, weight management clinic, pain management, and neuroscience. And we coordinated our care with our acute behavioral health, which happens to be at my hospital, St. Charles Hospital. We have a 90-bed behavioral health inpatient unit at St. Charles. So we did a lot of coordination of care with them. And we also added 8 behavioral health providers, bringing our total number of outpatient providers to 10. Just one of the ways we are trying to respond to the crisis, not just for our staff, but also for the increased patient volumes that we were seeing because of COVID-19. More and more people were depressed. More and more people were having psychological issues and other issues that they needed to talk to someone about. So just in closing, a little bit about healing. If you know a healthcare worker who's struggling, just some tips. Acknowledge their pain and struggle. Listen more than talk. Encourage self-care activities like exercise, rest, outdoor activities, faith activities. We were given an app. I think I had it here somewhere. There's various apps that we can use nowadays that we can share with people to help them with mindfulness, relaxation techniques, the ability to deal with PTSD or anxiety. And I do have that somewhere here in my notes, but we would share some of those apps with staff who are facing difficulties. And we need to encourage them to seek out and share social support, which may need to occur virtually for now, but hopefully that's opening up a little more. And then most importantly, this is the hard part, encourage them to schedule time off work for gradual reintegration into personal life. That's the really hard part, getting healthcare workers to schedule time off because they feel so committed to their work. They do not want to walk away at this time. Luckily, it's been improving. And if stress persists for longer than 2 to 3 weeks and interferes with normal functioning, healthcare workers should consider participating in formal mental health treatment. And the most important thing is keep listening, for it's the first task of love. I did bring a few handouts. I don't think I made that many copies. It is from the National Centers for PTSD, managing healthcare workers' stress associated with the COVID-19 outbreak. So just some tips on if you know anyone in healthcare who's dealing with stress right now due to COVID-19, some helpful tips. And that's it for me as far as slides. Now I'd like to open it up to questions or discussion. Sorry, I kind of went through a very quick, broad brush there.
That's great.
I tried to capture as much as I could in a
comment
short
or
time.
Question,
Yes.
Edwina.
I have a friend who refuses to have the injections. She's never had a flu injection, and she's refused to have this injection. She's going to a friend's house for a party next month.
Okay.
And her friend, my friend is going to ask her to wear a mask.
Uh-huh.
But we're not going to wear masks because we've been injected.
You've been vaccinated. Okay.
So, what do you think we should do about her?
I think you should as gently as possible, encourage her to wear the mask.
But she
That would be the safest thing to do. Not having been vaccinated. Unfortunately, we haven't reached the number of vaccines that we need to reach herd immunity. We're a long ways away from that yet. So it's not safe yet.
See, she says she's never had a flu shot, she's never had the flu. So why should she get this?
Yes.
She's older than I am, she's 84.
She's really in a high-risk group. We'll let our expert here answer that.
I have another question. I heard on the news in California that they think they're going to reach herd immunity not because they're administering enough vaccines, but because people who have already suffered from COVID have the antibodies built up. So they think, this was a number of weeks ago, it could have changed, so take it with a grain of salt. But my question is, do you have any information on being able to reach that herd immunity without necessarily administering all of the vaccines that is recommended to get us there that way?
Well, I could tell you that as of May 18th, just Ohio, we've had almost 5 million individuals who have had at least one dose, which is only 42.6% of Ohio. And only 37.1% of Ohioans have been fully vaccinated. So we're nowhere near herd immunity in Ohio.
Isn't the number something like 60?
Yeah, right, well, this is at least one dose. So are you talking about herd immunity?
Yeah.
It's actually more like 70. 70 would be ideal. Go ahead, doctor. I'll let the medical expert give an answer on that one.
There are only 4 states in the U.S. that have reached 70% so far, and the last one was yesterday, actually. Ohio's nowhere close.
No.
Answering your question specifically about letting people get sick and, okay, we'll develop herd immunity, we have to keep in mind the burden that it applies to the society. And, you know, many of these patients, around 30%, have side effects long term. The fatigue, the mental blurriness, and so on. Yay, they survived it, but there's also a lot of stuff that happens. And the other thing that we very often overlook is the fact of, yes, this person gets sick, but everybody around them, the burden it puts on the people around their caretakers and so on. So it's a great idea if we can get herd immunity
I'm
that
not
way.
condoning it, I'm just asking the question. I'm vaccinated. I just was thinking, at worst case, is there hope in getting, if people are gonna get it because they're not getting the vaccines, is there any hope that way? But if we're that far away from the numbers.
I think that's a bit of a, kind of like it works both ways. I mean, I think both need to work together, the vaccination as well as, I got the vaccine, and some people are like, oh, the side effects and so on. I had fever, yes. But at least I'll know that down the line, it's going to be a little helpful. And thank you for mentioning the PTSD. And, to be honest, it's going to be very difficult to reach the physicians and the nursing staff who will admit to the fact for all the mental stress that it's been a year and a half practically of continuous mental stress.
Right.
We're going to see the breakdown in the healthcare system within a year and a half, when all these people start showing those effects, because PTSD sometimes doesn't show up immediately.
Right.
The problem is admitting to the need for the help is where the problem happens. Because in the healthcare system, if you admit to the mental health, this is a taboo, a big taboo, for a doctor to tell you that he's not feeling okay,
Right.
or a nurse to admit to that fact. And I promise you, nurses at Mercy and ProMedica and UT have seen a lot. And it's not fun. Even the residents, it's a lot of mental stress that it puts on everybody, but it's figuring out how to tap into that to get them to admit to the fact that they need the help. Now, Mercy has systems, ProMedica has systems in UT where they can reach out behind the scenes, something called like EAP, where they can reach behind the scenes, and if they need pastoral care, nobody discusses that. But the problem is, this is going to happen on a larger scale. We're going to start seeing it across the country probably in a year and a half. We're going to see more and more people walk away from healthcare on all levels, whether nurses or physicians, or need the medical healthcare, mental healthcare support.
And one thing I might add too is to your question about not enough people getting in. We did start the Vax-A-Million program, and we saw last week a 50% rise just in the week from the week before. Whether that solves the problem long term, I don't know, but we've seen an overall 28% rise in vaccinations since we rolled out the Vax-A-Million program. And other states like New York are trying some other approaches to increase their vaccination rates. But as Dr. Zorb said, we're still a long ways away from herd immunity here. A lot of work to be done.
Last week, we had a speaker, our Resco, talk about trauma, and that I think it's an opportunity for our society to further reduce the stigma of these kind of, life issues.
Yes.
And it applies a little bit in your situation, Edwina. we can persuade people just to a certain point, and then we have to,
We agree.
accept them and all that. You had your hand up.
I did. I just wanted to ask you, we have many healthcare workers in our family, and I was going to ask you if Mercy, Bon Secure, or on a widespread basis, are offering specifically mental health care to their workers for no cost. They should be able to see someone and not have to go through the insurance dilemma, because this is coming from their very dedication to their profession.
Right, so good question. We do have the EAP program, and ours happens to be called Be Well Within, where there's a number, 800 number, you can call it anytime, to schedule counseling appointments free of charge. That is free. It's outside the insurance system. It's not like making an appointment with a psychologist on your own, having to pay the copay or this is actually offered through the EAP system. So
are you getting a response to that, a good response?
I don't see the numbers. That's kind of confidential, but from those who I've talked to, I think quite a few people are availing themselves of those counseling sessions. I did mention pastoral care. We have a number of full-time chaplains that work at our hospitals but that's a little different. Pastoral counseling is a little different than psychological counseling. But we do offer the EAP program, which is free of charge. But at this point, we're going to need a lot more resources.
Yeah.
Long-term, as I agree that the effects of PTSD often don't hit right away. It takes time as people process through that difficult period, and then they one day wake up and their world's changed, their view of reality.
We have a question over here, and then I'll get back to you.
I just wanted to comment on how I'm a retired nurse, and I'm so impressed by what the healthcare people have done in stretching themselves every which way. I can't imagine what's going on in those ICUs. We were so impressed when we got our shots. We went to St. B's, and the outreach they're doing with the fire department into the neighborhoods and all these, it's amazing, and I am truly impressed, and I just can't thank the health professions enough.
Thank you.
Scott, do you mind coming over here?
Sure.
Or you can.
I was just going to try to do it alone. I simply had the thought, and I thought maybe you might have an answer for this. The same trauma that's affected our healthcare workers is, in particular, those who've lost loved ones. There's a lot of trauma in all those families across the United States. Are they being offered some help?
So I did talk a little bit about us increasing our behavioral health resources at Mercy, our outpatient services. We've seen a rise in those visits to our outpatient visits to our psychological counseling services. I'm not quite sure we need more practitioners. We need a lot more psychologists, licensed social workers, and others to help address the needs of the general population, which, if healthcare is facing it, imagine what all of you have gone through if you're not even working on the front line, but you've also lived all of the trauma of COVID. Maybe it's job loss, it's social isolation, maybe you lost a loved one, you didn't have the ability to grieve. There's a multitude of problems that people are facing that need to be addressed, and I see a looming mental health crisis. It was bad before, it's probably going to get even worse. I talked a little bit about substance abuse issues. Those will have to be addressed as well. Unfortunately, I'm sorry I wasn't able to make last week's session, but it sounds like it was a good one.
Yeah. And Barb's going to present more on that in the fall. The other thing I've heard comment last fall, I think, was how many clergy maybe stepping away after this year, and teachers. Those are the two other professions that have been quietly working very hard.
Yes,
Sarah?
I could tell you that maybe Foster could mention this as well, but a lot of parish clergy have had a difficult time working through this, having no congregations or the inability to gather and worship. My home parish of St. Paul's in Cleveland Heights didn't gather at all for a long time. A very large parish. Very difficult for those folks. Fortunately, here at St. Michael's, we were able to make some accommodations to allow us to gather on a smaller level. But the whole parish, many parishes haven't gathered at all yet, or they're just now starting to break open, and as the guidelines are relaxed a little bit.
Let's hear from Danny, and then we'll be winding up.
We keep talking about physicians and nursing staff. We very often forget about the firefighters, the police, and everybody. We don't realize, for those patients to get to the hospital, those people are also putting their lives at risk. And many of them have been exposed on that, I think the one thing maybe that it was a very positive thing that came from this is how everybody pulled together, and we start appreciating certain jobs that in the past, they're doctors, so they're like whatever, golden or whatever. But you realize, first, like the frontline workers and the people who work at Kroger, who are supporting everybody, making sure they get their food, all of these people, and we start realizing everybody in society is very important. As you might look at them as, they don't do an important job. No, everybody has a very important role. And I think the key thing is once we start looking at this PTSD concern, they are also at risk of that. Maybe at a different proportion, but they're still at risk. The police, the firemen, because they are coming home and literally picking up these people, getting exposed and stuff like that. So I think when we look at the concerns for PTSD, it needs to be not just limited to nurses and physicians. It needs to be a little bit broader. And that's going to be the next strain, I think, on the healthcare system, is figuring out how to mentally support all of these people.
Yeah.
Well, thank you so much, Dan.
Thank you.
Appreciate it. We've been talking, and I know we have another topic or two that we may have you next year.
Absolutely.
And share. So
Thank you.
thank you.
Thank you.